Welcome, everyone. I'm Dr. Jess Heron, Chief Executive of Action on Postpartum Psychosis. Thank you for joining us today for our lunch webinar in collaboration with the National Centre for Mental Health at Cardiff University and GPs Championing Perinatal Care, the GPCPC. Today's webinar is supported by a Department of Health and Social Care Suicide Prevention grant. It's the second in our series of annual webinars delivered in memory of Alex Baish. The aim of the series is to draw together key knowledge for health professionals to make birth safer for people who experience postpartum psychosis. Last year's seminar for midwives and antenatal educators was booked on by more than 2,500 health professionals, and it's been watched online 2,500 times. Everyone who completed the feedback said it would change their practice. This year's webinar is aimed at GPs, but it will be relevant for a range of health professionals. 3,700 health professionals are registered today. Please submit any questions you have to the panel using the Q&A function at the bottom. We don't have time in the hour to answer your questions, but we'll put together a podcast and send it round as a resource after the seminar. The chat function is also open and we'll post useful resources in it as we go. Today, we'll hear from Richard Baish about what he hopes we can change with this seminar series. From author and publisher Catherine Cho about the impact of postpartum psychosis on family life, the risks of PP, and why we must be armed with knowledge. From Dr. Rock Cantwell, retired perinatal psychiatrist and advisor on perinatal mental health to the Scottish Government, and past author on the confidential inquiries into maternal deaths. Dr. Sally Wilson, who's health professional training lead for APP. Professor Ian Jones, Director of the National Centre for Mental Health at Cardiff University. And Dr. Judy Shakespeare, a retired GP and Deputy Co-Chair of the GPCPC. We know this will be a difficult topic for many people. It is being recorded today, so if today's not the right time for you to be watching, please do take care. We'll send out the recording so there will be other opportunities to watch. If you have personal experience of PP, we've got peer supporters available all day on the APP forum. The link's in the chat and they're there to talk if you need to, or just jump on and say hello. We'd love it if you'd spend 4 minutes at the end of the session filling in the feedback form to help us to further develop these webinars to meet your needs. I'd like to warmly thank Richard, his family, friends, and everyone who supported him for making this webinar series and our antenatal education campaign possible. I'll hand over to Richard to tell you more.
Thanks, Jess. Thanks, everyone. So my name's Rich Baish. I'm a teacher, as was my wife, Alex, until 2 years ago when she lost her life to postpartum psychosis. For the briefest spell, 2 years ago in autumn 2022, Alex and I had everything that we would ever have dreamed of. We had two beautiful children, we had a lovely home, two jobs that we loved, and we couldn't have been happier. And then out of nowhere, with no record of mental illness at all, Alex took her own life. The timeline of her deterioration was very quick, it was dramatic, and it was very sudden. I returned home from the Friday, from school, signaled the start of our half-term holiday, and she told me that she was sick. I didn't know what to say, I didn't know what to do. I didn't really recognize the severity or the gravity of what she was saying. At this point, I'd heard of baby blues, but in all honesty, I didn't really do a great deal with it, except to listen and to talk to her mum. She told me that everything was feeling exhausting, that she couldn't handle the most basic of functioning tasks. At the time, I put this down to anxiety and fatigue with a newborn baby who like to take up a lot of your nights and evenings. This is kind of a normal thing, and I tried to tell her that things would soon settle. We went for a walk as a family the next day. We tried to keep things as non-taxing as possible over the weekend. Alex booked herself in with her GP on the Monday, who prescribed her with antidepressants, and she booked her in with a mental health professional for 3 days later. However, that same night of her appointment, she left the house at night, and we never saw her again. There was a teacher, in the same way that I don't tell a child off in my class if they don't understand something that they've not been taught. I hold absolutely nothing against her GP because she hadn't been trained to spot those signs of postpartum psychosis, what they might look like, and therefore what she needed to do as a result. From what I've read and what I've researched over the last 2 years, very little time is dedicated to postnatal depression, let alone postpartum psychosis, during medical training. Ultimately, what I want everyone to be aware of is that PP is treatable with immediate action and the correct procedures. People do recover from it, and that's why I'm so thankful to everyone here for giving up your lunchtime, a portion of your day, whatever it is, to learn more about PP, what it might look like in patients. Every case is different, that everyone can be so varied. But in all cases, it needs to be treated like a medical emergency, just like a heart attack would be. Now, I vowed at the time, and it's very much a promise that I hope that I've kept so far, that I'd turn this situation into as much of a positive as possible, from a societal point of view, at least. If Alex's death is able to help us save 5 lives, 10 lives, 1,000 lives, then through raising awareness to family members, GPs, and wider health professionals across the country, then as much as the pain will stay with me and my family as it does every single day, I'll rest easy knowing that Alex's legacy will continue to be a positive one. They say it takes a village to raise a child. Well, I'd also say that it takes a village to get a family back on its feet after suffering a loss like we have. The support has been overwhelming, and I'll forever be so grateful to people for helping me and my family reset and readjust. But stopping this kind of event at the source and treating it immediately will negate the need for this. So I urge everyone to learn to spot the signs and realize that it's absolutely a real threat, and it can, if we do things properly immediately, help save people's lives. Before I pass you on to Catherine Cho, I just wanted to say an immediate thank you to everyone at APP, everyone here today for putting this on today. And I can't stress enough just how an amazing an organisation APP is. So yeah, that's it from me for now. Thank you.
Hi, I'm Catherine Cho. I'm one of the ambassadors for Action on Postpartum Psychosis. I'm a literary agent and author. I experienced postpartum psychosis in 2018 after the birth of my son. Like many other women who have postpartum psychosis, I had no history of mental illness. I had decided to use our shared parental leave to take an extended trip to the United States to visit our families. We crossed the country, and after many sleepless nights and hearing the concerns of our families who thought we were being reckless, I looked at my son's face and I thought his eyes were devil's eyes. He was 3 months old. In my psychosis, I lost sense of time. I was experiencing moments in repeat, again and again. I thought I was a character in Dante's Inferno. I kept seeing my son dying, my husband carrying the body of a baby in his arms. I could see figures running out of the room, and when I was walking outside, I could feel demons pressing against me in a crowd. I can still see their faces, and even though I know that this wasn't real, it feels real to me. My husband didn't know what was happening. He noticed I was speaking strangely, that I couldn't sit still. I didn't tell him about the demons I was seeing. I didn't tell him that I thought our son's face looked like a devil's. He would end up taking me to the emergency room because he happened to message one of our friends who said, "Just take her." When we got to the emergency room, I started stripping off my clothes. I was struggling with the nurses. I thought they were devils, and I thought I was going to remain in a hospital for all of eternity. I was given a series of medications that did not work, and after a few days, I was taken to a general psychiatric unit. I remember when I was being checked in that the workers were being rough with me. I think they were scared, and my husband was trying to come into the room with me, but they wouldn't let him, and I could sense his fear. I remember fighting with them and urinating on the floor. I was sedated, and when I woke up, I felt like my brain had been scrambled. I would spend a total of 10 days away from my son, and when I came out, we flew back home to the UK, and I had to start the process of recovery. I couldn't touch my son. It was too difficult, and it felt wrong. My husband had to figure out how to take care of both of us, and I remember he would sleep in the hallway, in between me in the bedroom and my son in the living room, because he was afraid of the way I was talking in my sleep. After my psychosis, I fell into a deep depression. I thought I understood what it meant to be depressed, but I had never experienced anything like this. It was like someone had turned off the lights. I couldn't move my face. I couldn't form a smile. I couldn't sit up. I would lie down and try and breathe, but it felt like there was something beyond, waiting to take me in, a nothingness. In many ways, this part of the experience was the hardest because it felt like it would never get better. I was under the care of a perinatal mental health team and psychiatrist who were incredible and so integral to my recovery. I was referred to a mental health crisis team, and they would visit me every day and check in on me, and I took so much hope from them. They told me that one day I'd be able to talk about this experience as something that had happened in the past. While I was recovering, I started writing about my experience. I wanted to share, without fear, without shame, what it felt like to go through psychosis. When I was at the general ward, the first group session that I can remember, we were asked, "How did you get here?" And I would think a lot about that, tracing the roots of this experience, trying to understand why. It became a memoir called Inferno, which was published a few years ago, and one of the greatest gifts of that book are the people who reach out to me to say that it helped them understand their own experience or an experience of a loved one. I know that I'm very lucky that I'm here, that I can talk about my experience as something that happened in the past. When I was undergoing psychosis, I was so convinced that we were already dead, that we were in the circle of hell, and I thought that the only way to escape it was to end my life. I considered it restarting, and I kept trying to talk to my husband about needing to restart. What helped me get better were the people and the support around me, and in my recovery, I would read stories of others who had been through postpartum psychosis. I'm a mother of 2 now. My son is nearly 7 and my daughter is nearly 4, and I have thought a lot about how I will talk to them about postpartum psychosis and what happened. I hope they'll know how much I wanted to get better, how much I wanted to come back, to be myself again. And what I find so devastating is that there are mothers who do not make it. And I hope that with events like these, by sharing our stories, we can make sure that we are aware of postpartum psychosis and that we can get women and families the help they need so that we can all talk about these experiences as something in our past. Thank you.
Hello, everyone. I'm sure you've all felt like me the power of the of those two talks from Rich and from Catherine. What I'd like to do is to tell you a little bit about what we understand about maternal suicide from the lessons we have from the confidential inquiries into maternal deaths. The inquiries have been going on since the 1950s, and you can see the progress in terms of the titles reflects a little bit more about what we feel we can do about that. So from why mothers die through saving mothers' lives to now saving lives, improving care for women and for their families as well. The other thing I wanted to tell you about the inquiries is that they're a mix of qualitative and quantitative information. So it's not just about the numbers, it's very much about the stories of the individual women and their families. And that there's a richness and a depth of information that helps us understand their experiences, but as importantly, helps us also think about how we can prevent other people and other families going through similar experiences. Thankfully, in a country like the UK, the number of women who die during pregnancy or after childbirth is actually quite small. You can see there this is over a 3-year period in the report that came out in 2021, and you can see 475 women in all who died, and the numbers below are just divided into those who died traditionally and during pregnancy and up to the first 42 days after childbirth, and then those who died from then until the end of the first year. And then on the right-hand side, you can see the numbers who died in relation to mental ill health. And you can see they're broken down into 2 groups. There's the women who died by suicide and the women who died in relation to substance misuse as well. And the numbers are almost equal, but I'm going to concentrate on the women who died by suicide today. You can see, just looking at the two groups in terms of the early deaths up to 42 days after childbirth, you can see that the psychiatric deaths account for as many as cardiac deaths, as deaths in recent times due to COVID as well. So they're right up there in a not enviable league of numbers of people who have died. And then in the late deaths, those that happen later on after the first 6 weeks post-delivery, you can see that if you combine deaths by suicide and deaths due to drug and alcohol use, then they make up almost 40%, so almost 4 in all women who die in the later parts of the postnatal period. And these are looking at those rates across across a number of reports. You can see that the numbers are roughly stable in terms of rates of death, but from suicide. But there's something different going on in the most recent report from 2021, and looking for suicides uniquely at just 1 year. And I just want to show you in a little more detail that. So the report that came out in 22 and looking just in 1 year, what was found then was that women were 3 times more likely to die by suicide during or up to 6 weeks after the end of the pregnancy compared to the previous report. So there's a recent change, which obviously we need to look at to see if that continues to be a trend, but that's concerning. And one of the other distinctive features about that are the increased number of women who are very young, who are teenagers, who are dying by suicide. And that's a relatively new finding in the inquiry. A couple of other things that we know is quite distinctive about people who die by suicide in the perinatal period. And we can see there that the mode of death, and quite distressingly, is usually by violent means. And this is usually men are more likely to use violent means to end their lives compared to women. But there's something distinctive and different about the perinatal period. You can also see that most of the deaths by suicide happen in the graph below in the bar chart, happen in the postnatal period. But you remember also that concerning finding from the most recent report about increased numbers of early deaths as well. Coming on to diagnosis and thinking about those women who have experienced postpartum psychosis or other form of psychosis, then from this report, we can see that we found about 28% of women had a probable or definite psychotic illness amongst those who died by suicide. And if you look, now these are very estimated figures, but nonetheless, if you look across a number of reports going right back to the mid-1990s, then the proportion of women who died by suicide who had a psychotic illness as opposed to another diagnosis, another mental illness diagnosis, fluctuates a bit because the numbers are very small, but on average, it's around about 3 in 10 women of those who die by suicide have a diagnosis of a psychotic illness, so a significant proportion. And the other important factor I think that we need to keep in mind is what sort of care these women got. So it's actually a small proportion of these women who actually had specialist perinatal mental health care. The majority of these women, or the largest groups, were looked after by universal care and by primary care or by crisis mental health teams. Coming on to some of the lessons we've learned, and there are many, many lessons, but trying to summarize some of the more relevant ones, then we, in 2015 report, came out with what we called the red flags, which were 3 particularly concerning patterns that we felt were associated with increased suicide risks. So the first was around significant changes in mental state or new symptoms coming out. The second was about new thoughts or acts of violence and self-harm. And the third were thoughts or expressions of incompetence as a mother or feeling estranged from the infant. And here are some stories from women in the inquiries that illustrate that. This is a woman, a history of lowered mood in the previous postnatal period. She had anxiety symptoms, but then there was a very sudden change in how she presented in the immediate time after childbirth. There was clear evidence that she had psychotic symptoms and that she'd attempted to end her life by violent means. She was seen by emergency mental health services, and they said that her act of harm had been impulsive and planned to review her again the next day. But even within that time, she had ended her life violently. So that that illustrates that pattern of very rapid change in how people present, very new sudden onset symptoms, and the very rapid progression and deterioration as well. And here's an example of a woman who illustrates that estrangement from the infant. So a woman with a much wanted pregnancy who had never experienced mental illness before, but within 12 days had gone to her GP saying she was depressed and wanted her baby adopted. Again, a very unusual pattern for her. And again, she died within a short time after that. We also, in a subsequent report, talked about amber flags, and this is particularly relevant for postpartum psychosis, because once somebody has had postpartum psychosis once, then their risk of having it in a subsequent postnatal period is significantly higher. So these are some of the most important factors that came out from the inquiry: any past history of a psychotic disorder, having a close family, having a close family member who has had postpartum psychosis or a bipolar affective disorder, and recognizing that the patterns that other family members might have shown in terms of timing of onset might well be repeated in the woman that you're actually looking after. And so in terms of recommendations around that, then we all have a responsibility, if a woman has experienced a postpartum psychosis, to think about her future risk, to be able to tell her about what can be done, because there are a lot of things that can be done to reduce that risk of occurrence in future postpartum periods, and the importance of being referred into perinatal mental health services during any subsequent pregnancies so that those preventative plans can be put in place. The other thing that I wanted to mention out of the inquiry was the consideration of inpatient care. So these aren't necessarily the only things or absolute reasons why somebody should be an inpatient in a mother and baby unit, but they're pointers to saying we should be thinking about whether an inpatient spell would be helpful for that woman. So again, things like rapid changes in mental state, violent suicidal ideation, pervasive sense of guilt or remorse, estrangement from the infant. So all of those red flag symptoms, and obviously the presence of psychotic symptoms or psychosis diagnosis as well. So for me, I just want to point out the lessons that I think are particularly important. So the most important question is this woman's presentation, is it different? Does it look different from how she normally is? Is there something unexpected and unusual about this? The second thing is about education for everybody. Do we all understand the particular distinctive risks that are present in relation to perinatal mental illness, and particularly postpartum psychosis? And thirdly, are we all telling each other about what we find if we're concerned about somebody? And are we including the family in those concerns? Are we letting them know why we're concerned? And are we listening to the concerns that they have? There are many other lessons that are important too, but I think that's the beginnings of perhaps some of the more important ones for you today. And I'm going to take the opportunity now to hand over to Sally.
Thank you, Rock. I'm just going to share my slides with you. Good afternoon, everyone. My name is Sally, and I'm APP's training coordinator and have a background in academia. So I'm going to talk to you very briefly about what we know through our work at APP about postpartum psychosis. So postpartum psychosis is a severe, frightening postnatal mental illness, which has a rapid onset and is considered a medical emergency. So for this reason, if PP is suspected, help should be sought immediately. And we'll talk a little bit more about that later on. However, with the right treatment and support, people can make a recovery. So those with a history of severe mental illness, such as bipolar disorder or psychosis, are at a higher risk of developing PP. And Professor Ian Jones is going to talk into more detail about this later. However, approximately half of those who develop PP have no history of serious mental illness. It affects those giving birth from all backgrounds, classes, cultures, and education levels, which is why it's vital that all frontline health professionals know about it. Postpartum psychosis occurs in about 1 to 2 in 1,000 people who give birth. Whilst it's not as common as other perinatal mental illnesses, as far as serious life-threatening complications of childbirth go, PP is one of the most common. So APP's YouGov poll in 2021 found that approximately 40% of the general population had heard about PP. So although awareness has increased over the last 10 years, it's much lower than other maternal illnesses. Also, only 6% of expectant parents had heard about PP in their antenatal classes. So using APP's existing resources and data from our antenatal campaign and survey, we've developed an antenatal education toolkit to support professionals, which we'll drop a link to in the chat. So you can also see here in the middle a video from midwife Marley, who demonstrates how easy it can be to have a short, life-saving conversation about PP. So our lived experience stories repeatedly show that lack of awareness of PP has led to delays in spotting the signs and symptoms and seeking help, significant trauma, and for some, as we've already heard today, tragic loss of life. We know that raising awareness and talking about postpartum psychosis can help to save lives. So the signs and symptoms of postpartum psychosis can vary amongst individuals, and typically they can happen very quickly after childbirth. However, in some cases it can happen later on. They can include mixed mood, which can change very quickly. So for example, feeling unusually elated, frightened, tearful, confused, racing thoughts, unable to sleep, unusual beliefs and hallucinations. So seeing, hearing or sensing things that others can't. We know that recognising the signs and symptoms of PP can save lives. Here is some work conducted by Jess Heron and the team. So in the middle of the screen, you can see the most frequently reported symptoms were feeling excited, elated, racing thoughts, busy mind, increased energy, confusion, no need or not being able to sleep. So acknowledging that in most cases, there are early signs and symptoms before the full-blown delusions and hallucinations. I want to point out that it's important to know what is considered out of the ordinary for that person, which is why family and friends are so important, and that these kind of symptoms should be monitored. So if we spot these signs and symptoms, we need to get help quickly, and this should be ideally the same day. So the other speakers are going to go into a little bit more detail about what that help might look like, but I want to ask you, if you suspect postpartum psychosis, do you know what your local pathway of care is? So we need to know about the treatment and management, and that should ideally include admission to an inpatient mother and baby unit, alongside lots of other interventions such as psychological and peer support. So mother and baby units are life-saving specialist inpatient units with a team of multidisciplinary specialist healthcare professionals who treat, care and support mother and baby together. We know that being admitted to a general adult psychiatric unit and being separated from your baby can be incredibly traumatic. We also have data from the APP surveys looking at care and recovery outcomes across different pathways of care. So as you can see here, we have the care outcomes in the middle of the screen. So positively, total satisfaction with care for postpartum psychosis in the UK has increased since 2010. So feelings of safety, feeling informed about the illness, confidence in staff and support with recovery have all increased, depicted by the pink and blue lines on this figure on the right. However, in all care and recovery outcomes, those who were treated in a mother and baby unit have significantly better outcomes than those admitted in general units. So we know how important it is to get the right care quickly. We know that recovery from postpartum psychosis can be complex. It's a very individual process, and unfortunately, we haven't got enough time to cover everything about that today, but I just want to point out a few key points that are relevant to today. So using data from APP surveys, we know that the average inpatient stay can be approximately about 6 weeks, but that recovery can take anywhere between 6 months to 3 years or more. So the initial psychosis can be followed by periods of depression, anxiety, low confidence and self-stigma. So often people will still be recovering when they're discharged back into primary care from secondary services. So importantly, APP found that over 50% of people who experience PP will have suicidal thoughts in the year after being discharged from hospital. The reasons for these feelings are complex and very individual, but an important point is that I want to make really is that those who have suicidal thoughts and lose their life to PP don't always have the typical risk factors that have been identified in the perinatal period. We also need to acknowledge that there's a risk in the acute phases of psychosis, but also in long-term recovery as well. So we know the impact of postpartum psychosis can happen, can take a long time. It takes time to come to terms with what's happened. The positive thing is that we know that some people who experience PP won't endure a period of mood disorder again in their lifetime. But we need to be mindful that up to half can experience further episodes of mental illness even after the perinatal period. So we need to think about your role in the acute phases, for example, identifying signs and symptoms, getting help quickly, but also what your role might be in the lifespan of someone who's experienced postpartum psychosis. We also know that recovery from PP has a significant impact on dads, co-parents, and the wider family. So a family often state it is a devastating time and one of the most traumatic things they've been through in their life. So APP's peer support service reflects the ongoing support needed for the whole family in long-term recovery from this illness. So this slide highlights the importance of peer support. We know that it offers hope in a very dark time. We also know that 1 in 3 people who use APP's peer support service said they might not be here today without it. And I am one of those 3. So when I was ill in 2015, my psychosis came on very quickly on the day I gave birth. My delusions involved me having harmed my baby, and I thought there was no way I could ever face anyone or carry on. This was 100% my reality. It was very scary, frightening, and it didn't matter how many people told me it wasn't true at the time. The only thing that kept me safe was being admitted to a general psychiatric unit and starting treatment. It was incredibly traumatic. I was separated from my daughter, and ideally I should have been in a mother and baby unit. I did have amazing health professionals advocating for me, but I had ongoing psychosis and severe depression. So during the depressive phase, alongside the psychosis, I had impulsive and constant suicidal thoughts. It was a battle every day to survive. I know not everyone can or does this, but for me, talking about these thoughts really helped me at the time. I talked with my health professional, my husband, and my peer supporter from APP. The only way I can describe it is that it acted like a tiny release of pressure each time. After 10 months of struggling, I was signposted to the information and life-saving treatment I needed, which for me was ECT or electroconvulsive therapy. It took me time to recover, but I am so far from where I was then. I know I'm fortunate to be sitting here presented to you today. My story could have easily been very different, but I also know that together we can do more. We need to make sure that all frontline health professionals know about postpartum psychosis. We need to know how to spot the signs and symptoms and where to get help. Know that recovery is complex and can take a long time. And importantly, we need to offer hope that things will get better. So thank you for listening. And I'm now going to hand you over to Professor Ian Jones.
Hi, thanks, Sally. And I'm absolutely delighted to be part of this webinar. It's so fantastic to see so many people registered and online. And I'm going to talk to you for the next 10 minutes about this issue, who is at high risk of postpartum psychosis. If I can get that to move. So the plan of my talk, I'm going to start off by saying something about why knowing more about who is at high risk is important. I'm going to give you my take on what the 3, maybe 2, maybe 3, perhaps, as we'll see, what the most important markers of women at high risk. And then I'm going to say something right at the end, very briefly, about how we should be managing women at high risk. So the first point I wanted to make before going on to talk about those issues are it's always important for us to remember that in 50% of cases of postpartum psychosis, there's no history that puts that woman in that high-risk group. They're the so-called out-of-the-blue cases. And as we go on to look at what the important risk factors are, it's important for us to remember that. So what about this issue then about why it's important to know who's at high risk? I think knowing who's at high risk will help us have those conversations, give that preconception advice to women and their partners, and help them make those really difficult decisions about pregnancy, and particularly around whether to stay on their current medication, to switch medication, or stop medication. For services, for the hard-pressed NHS, I think it's important and will help us identify those women that really need that close monitoring through pregnancy and the postpartum period. And a further factor I think is really important to take into account is that nowhere else in mental health care can we be faced with a woman who's currently well, who we know has a 40, 50, 60, or even higher percent risk of becoming unwell in this very defined period. So there's really an unrivaled opportunity, I think, to work with women preventatively. And I think, that's an area that we need much more research on, knowing how to best help that woman. But the main reason why I think it's important is that it's something that I think we don't do particularly well at the moment. This is work from a fantastic colleague, Claire Dolman, who's a trustee of Action and Postpartum Psychosis with lived experience in postpartum psychosis and bipolar disorder herself. And this, for her PhD, she did a qualitative study of bipolar women, really looking at their experience of pregnancy and the postpartum period. And what came out of that very clearly is that women found it very difficult to get the information they needed to make those difficult decisions, with one woman saying it was like bashing her head against a brick wall. So, what are those markers? Well, I think, I could talk for a long time. I've only got 10 minutes today, so I'm going to really focus on what I think are the most important clinical markers. And the main one, I think, is a past history of severe mental illness or psychosis, and in particular of bipolar disorder. There's lots of lines of evidence to suggest this, but perhaps the best evidence comes from the work of Trine Monk Olsen, fantastic colleague who's been doing work in Denmark for the last couple of decades, linking up the registered data they have there of pregnancies with psychiatric admissions. And if you look at women who've had a previous admission with a range of psychiatric illnesses, what Trine was able to do in this study was to find that there really was a particular relationship with a history of bipolar disorder putting women at high risk. The top line there is for women with a history of bipolar disorder and this is what women being admitted in the first year after childbirth. And what you see is for women with a history of bipolar disorder, this massively increased risk of a severe early onset episode of illness resulting in admission. Almost 20% of women being admitted with a history of bipolar disorder in that first postpartum month. Now, the other important point to make, and this comes from the work, from our work in the National Centre and the Bipolar Disorder Research Network, is that if we look at the risk across that spectrum of bipolar illness, it's women with the most severe forms of bipolar disorder, the so-called bipolar 1 disorders, they're at particular high risk of bipolar disorder. If we look at women with bipolar 2 disorder and working with women with recurrent major depression, they are at high risk of a perinatal episode, but it's the bipolar 1 women who are at high risk of a postpartum psychosis-like episode. Second important marker is a previous history of postpartum psychosis, and this is even higher risk than women with bipolar illness. This is a study that we've also comes from our work at the National Centre. This is where we were able to look at data from almost 700 women with more than one pregnancy who had a diagnosis of bipolar disorder, and we were able to demonstrate for the first time really that what happened in their first pregnancy, whether they suffered a postpartum episode or not, predicted the recurrence in future episodes. All of these women had bipolar disorder, remember, but we were able to differentiate women who had bipolar 1 disorder, who'd had a postpartum psychosis, were at an almost 45% risk in their subsequent pregnancies compared to women with bipolar 2 disorder who had not had a perinatal episode in their first pregnancy. Their risk of postpartum psychosis was around 1%. So really some very compelling, strong evidence there that, a history of postpartum psychosis is a really strong predictor of risk. So what about, that's the first two factors. What about the third factor? I'm going to say something about the importance of family history, because I think it's really important to be clear what the literature shows here. Undoubtedly, family history of bipolar disorder and even more of postpartum psychosis increases the relative risk of postpartum psychosis. But because the risk is low in the general population, the absolute risk remains low. So for an illness that affects something like 1 in 500, 1 in 1,000 in the general population, having a family history of postpartum psychosis, for example, in a first degree relative, in a sister or mother, the evidence suggests a risk of 10 to 30 for 1 to 3% risk of a personal postpartum psychosis if the woman has no history herself. What is undoubtedly true, though, and that what we've shown in our research is that for women who have a history of bipolar disorder, a family history of postpartum psychosis is important in extra risk and almost doubles risk. So identifying these women are vitally important. So just to finish off then, before I hand over to Judy, what should we do then if it's a personal history of psychiatric illness, severe illness, particularly bipolar disorder, that really is an important marker? We really need ways in which all women in pregnancy are asked questions about that history. Bear in mind that women with bipolar disorder may be currently very well, even if they've had previous very severe episodes of illness, they may be well, not in contact with services. So asking the question about that history is really important. And if women are identified with that history, then they should be referred to specialist perinatal mental health teams. If locally, your local specialist perinatal mental health team isn't wanting to see these women, then let APP, let me know, because we very much feel that they should be seen. And then with the assessment by the perinatal team then should result in a collaborative decision based on that individual woman's history of illness and a treatment response, looking at all options, remembering that no options are risk-free, but important point to make is that for many, maybe even most women, continuing medication may be the best option. And then lastly, just before I finish, it's always worth remembering that it's not just decisions about medications that are important here. Other aspects of managing, psychological, social managing, and really working out how the woman will be kind of very closely monitored through pregnancy and the postpartum period, how she can get help quickly. These are also vitally important aspects of management as well. So giving you a really quick talk today, focused on what I think are the most important markers of high risk. That's a kind of personal history, particularly of bipolar disorder, particularly of history of previous postpartum psychosis, and in those women with a personal history of illness, a family history of postpartum psychosis, I think those are the most important clinical markers. With that, I'll hand you back, and I think we're going to hear from Dr. Judy Shakespeare. Thank you.
Hi, welcome to this session where I'm going to be talking about practical tips for GPs. I've been working in this area for a very long time, but it is fascinating and tragic. So what is the role of GPs? They certainly have a role in this condition. So I think it's really important that they're aware and they're educated about who might be at high risk. And you've heard all of that earlier. And ensure that women who might be at higher risk have a management plan in place before they have their babies. Having said that, the first point of contact is likely to be the GP, especially since, if you remember, 50% of women have no previous history of mental illness. It's important for us to advocate for the right care. And that means, in the case of psychosis, rapid care by hopefully a perinatal mental health specialist and hopefully in an MBU. And it's important for us to escalate things if necessary, if the first people who assess the woman don't seem to feel the same that you innately feel. But supporting the acute illness is only one part of this. We also need to support women's recovery, which will take many years and often will be really, really hard to come to terms with. And we also have to be involved in future pregnancy choices, relapse planning, and be aware that the menopause may be another time when women have difficulties. So when we're talking postpartum psychosis, we're talking urgent referral. That means within 4 hours of first becoming aware of the symptoms, because things can change so quickly in this situation. So do you know what the referral pathways are in your area? Are you supposed to call the perinatal mental health team in hours? Who are you supposed to call out of hours? Might it be the crisis team, or should you call 111? And of course, in some situations, but this isn't really ideal, you'll need to call 999 for an ambulance. Police may not be involved in all situations, but the bottom line is this: if you think it's psychosis, don't wait till tomorrow. Pick up the phone and sort out some help, and keep the woman and child safe as well. Don't leave the family to supervise them alone. So tips for assessment. Well, it's always going to be out of hours, isn't it? And it's out of the ordinary. It may be that somebody's recognised that something isn't quite right. Often it's florid, the way that the women present, but it may be more subtle. It may be varying very quickly. They may be depressed, they may be manic, they may be terrified, they may be able to hold it together for an hour. Involve the partners or someone who knows the patient well, because if they are holding it together, then we need to know that something is seriously wrong. Ask open questions. Just be curious, be kind, take time, and take it seriously. It may have been really difficult for the partner to organise for a GP to be there, may have involved some ingenuity and deception. So just give it time. Tips for dealing with women when you think they might have psychosis. Focus on feelings and don't confirm or deny it. Say things like, that must be very frightening for you, and be warm and calm and compassionate. Explain things, ask about fears and concerns. Being confrontational or denying their problem will make them feel worse and might exacerbate things, whereas talking about it might calm things down a little. We do have to ask about suicide, clearly, and just to dispel the myths about suicide. Asking about it doesn't make it more likely, and having a child in this situation is not a protective factor. Women may say that, but professionals shouldn't rely on that being actually true. So probing, you need to probe directly. Have you thought of ending your own life or harming yourself? Or things like, I've noticed that you seem withdrawn or terrified or something like that. Sometimes when other people have been like that, they've been having suicidal thoughts. If that Is that what's happening to you now? And of course, they might say yes, in which case you have to treat it as an invitation to try to help them, not just to refer them. Try and bring their thoughts into today. What's happened today to make you feel exactly like that? Try to get them to express themselves, to talk, and that can release pressure. Suicidal thoughts are terrifying and irrational. And just talking, taking time can help them get their thoughts into order. I can thoroughly recommend this website for trying to plan for safety in suicidal risk. And you need to think that suicidal thoughts may be different in different phases of the illness. The psychotic illness at the beginning of or just after pregnancy is likely to be very impulsive and reckless, whereas the deep depression that will often develop later is a very different kettle of fish. What about managing risk to the baby? Well, get help quickly for the baby as well as for the mother. Keep them safe, as I've already said. Don't leave the family to supervise. The safest place for the mother and the safest place for the baby is an MBU. I'm just going to say that you need to recognize the difference between postpartum psychosis and thoughts about harming the child from intrusive thoughts in perinatal OCD. I'm not going to go into that in any detail, but here's a paper that you might look at, which might be helpful. So, recovery and planning for the next pregnancy, understanding the GP scope. GPs shouldn't be expected to manage the medication if women are actively being treated by psychiatrists. Their job is to listen, support, advocate, and escalate, as I said earlier, if necessary. They need to understand that there's a suicidal risk during recovery, particularly in that very depressed phase. And they need to help the woman plan for the next pregnancy. But they need to manage expectations as well. This illness goes on for a long time, as I've already said. And as I've already said, the depression is often very serious after psychosis, and the suicidal risk continues. However, you should expect the woman to make a full recovery and offer her hope of that and the family in the course of the illness. So, just to finish off, GPs are part of the solution to this problem. Thank you.
Thanks, Judy. A sincere thank you to all today's speakers for sharing their time, passion, and knowledge to help make birth safer for new families. Whatever your role in healthcare, we'd be delighted if you would join us in helping to increase public and health professional understanding and awareness of postpartum psychosis in whatever ways you can. If you need resources to train your team or have ideas about other ways you can help, please do get in touch. We know that in an hour session, we can only just scratch the surface of this topic, but please do sign up for the APP newsletter. GPs can also join the GPCPC. And to access more in-depth training, visit the training section of the APP website. If there are specialist topics or online or on-site sessions that you'd like us to run, get in touch with Sally at training@app-network.org. You can donate to support APP's work with mums and families using the link in the chat or the QR code on the end screen. We've also got a whole host of challenge events, runs, walks, skydives, bake sales you can get involved with as an individual or as a professional team. So with the last couple of minutes, I just want to hand back for a final word from Sally and Rich.
Thank you, Jess. I just want to say a massive thank you really for you for giving up your time, for being here today. But also without people like yourselves, I probably wouldn't be sat here talking to you today. So thank you for everything you do for families affected by postpartum psychosis. But now we need to do more. We need to get the message out to those who aren't here today. So please help us to do that by disseminating today's events and resources and messages far and wide. And with that, I'll hand you over to Rich for the last word. So thank you.
Yeah, just to reiterate everything that Sally and Jess have just said. Just from the bottom of my heart, the biggest thank you to APP, to all of our fantastic speakers in the last hour, everyone who's left really lovely messages on the chat, everyone who's listened and watched. And I just need to share this with you that my friend was watching, and she's a social worker, and actually just said that you won't believe this, but within the last hour, she's asked one of her other social workers to get a new mum to hospital by ambulance because she appears to be having a mental health breakdown. I mean, wow, that's such a positive thing to happen, for people to start being proactive. And I think the main message that I want people to take away from this is, what's the worst that can happen? What's the worst that can happen if you rush your friend, your loved one to hospital, wherever it may be, into the hands of health professionals? What's the worst that can happen? They turn you away, they say you're okay. That's the worst that can happen in that case. We know the worst that can happen if nothing is done. So err on the side of caution, look, listen and act. And I know that we're making a difference already. So thank you again.
Thanks, Rich. So thank you massively for spending your lunchtime with us. There's a link to the feedback form in the chat and via the QR code. We'll send around the resources to everyone that's registered today as they're ready. And thanks very much. Enjoy the rest of your day.